really excited to follow on that opening address by having this panel discussion. I want to briefly introduce you to our speakers. We've got Prof. Ngaire Woods, who's the founding dean of the Blavatnik School for Government at Oxford University. We've got Dr. Jessica Davis, associate research scientist at Northeastern University in Boston. And we've got Dr. Merawi Aragaw Tegegne, head of division for the Health Emergency Preparedness and Response at Africa CDC. And so as you can surmise, we've got many of the people on the stage today that played key roles in the initial stages of the COVID-19 response and have continued to do incredible work. And what we hope to do is set the stage for the rest of the discussion. So if we're planning to say what infrastructure that we need that wasn't in place, let's focus on what was the experiences of the first 6 months of the pandemic. So,
great. Well, so I'm going to talk about politics, and I'm going to bring good news, which will lead you to believe I've been taking illegal drugs before I get here. Sitting in Oxford, I watched Oxford's brilliant scientists, many of whom are in the room, go with tremendous excitement and optimism about what they were doing and how this could address the pandemic, head down towards Westminster in Whitehall, filled with optimism, and then I would watch them come back, depressed. To quote one who I would never name, it's a shit show down there. So I want to talk about why it doesn't have to be and why there is a clear path for making sure it's not. My own view is that the biggest obstacle to pandemic preparedness and response is political. It's not scientific. I have great confidence in the scientists in the room. Now what we've got to do is make the politics work. So John Bell started this morning by saying he's depressed at the way politicians are already well out of there. They're on to the next crisis. So my first element of good news is we've seen this many times before. My normal area of expertise is financial crisis management. Two American scholars wrote a book about the way politicians in every financial crisis say this will be the last because we're going to get it right next time. And they sarcastically called their book, This Time It's Different, 800 Years of Debt Crises. But that isn't my point. My point is actually that since 2008, even after the spotlight turned away from the financial crisis, we have seen some steady and important reforms. And I think we need to learn from those reforms and that reform process for pandemics. In other words, how do you succeed in pushing reform forwards, some systemic reforms, even when the spotlight has gone off? The second point I want to make, John mentioned, that politicians are now focused on climate change, and I would add on the migration crisis, Ukrainians, Afghans, here in this country and in other countries. So here's the good news. One of the things that we've just completed at the Blavatnik School is a report on how to reform the government's crisis mechanisms. And the good news is that actually pandemics, climate change crises, and migration crises share some similar features which the existing systems for crisis have not been engineered to resolve. So our crisis management system in most governments is focused on crises like terrorist incidents or industrial accidents or geographically contained natural disasters. So they're bounded by time, they're short term, they're bounded by geography, they're quite specific, and they're bounded in population terms. They only affect one small sector of the population. Pandemics, climate crises, migration crises break all those three constraints. And as a result, what we do on any one of those three is going to help how we manage the other two. So that's another piece of good news. So let me then just very briefly talk about what we need to do and how we can get this right. So the first of the sort of systemic things. So our long emergency report highlights three things about the system, political systems itself, and we compare the United Kingdom with Germany, Italy, Australia, and Singapore. And three things stand out for me that we have to get right, that we can get right. And the first is establishing trusted relationships between governments and good parts of the private sector. Sounds simple. Listen to Kate Bingham on this. Her walking into Whitehall and Westminster and finding people who see the private sector, even when there is a government from a political party that sees itself as private sector friendly. Politicians and civil servants who see the private sector purely as predatory and opportunistic. And that makes, in fact, what that leads to is the government working with the most predatory and opportunistic parts of the system, because they don't have a set of trusted relations to actually work with. But they have in other countries, and they have in other times in Britain. So the first priority, it's not a first priority, sorry, one priority is to re-establish those trusted relations so that there is a foundational set of relations which can be tapped into when we hit a crisis which requires procurement of quality at speed and at good value. We saw the exact opposite in the first 6 months of the crisis in Britain. The second is the relations between central government and local governments and cities. So in Britain, you've actually got enshrined in legislation that local governments bear a large part of the emergency response duties. And yet there's no funding that follows that, there's no data sharing, and most important of all, there's no trust from central government towards those local governments. And so the system slewed. It veered from a centralized approach to July 2020, actually let's throw it onto local governments who had none of the capacity, none of the funding, and none of the data to actually fashion their own approaches. That can be resolved. The constitutional setup giving local governments those powers was one which assumed certain capacities, and in the very first instance, the government can invest not huge sums, but adequate sums in local great data collection fed back to central, and in local emergency response. The third is, in Britain and in other federal countries, the relationship between England, Scotland, Wales, and Northern Ireland. And what COVID showed Britain was that there was a confusion in the minds of central government about what devolution meant. So you had a prime minister speaking for the United Kingdom when in fact he was actually speaking about England, and Wales, Scotland, and Northern Ireland each had their own approaches. And it also showed us that there weren't any consultation mechanisms. Whereas if we look at Australia and Germany, we saw them very quickly, because there was greater clarity about the constitutional setup, create consultation mechanisms. So there's 3 things we can do on the political structure: trusted relations with private sector, clarity between and more trust between local government and central government, and clarity about the consultation mechanisms with devolved administrations or in federal systems between states and central government, which fell over in most countries. Very quickly, what we then learn about the specifics of crisis management is first that we need to embed a range of scenarios. Don't just have a COBRA system which looks at responding to a terrorist incident. Ensure that you've got the whole of government thinking, not just one lead government agency, and all of, not just Britain, but many countries have designated one lead agency. What we discovered in COVID is you actually need Treasury and the Education Department, as well as the Health Department, to have a preparedness around COVID. The second is Britain, like other countries, had done theoretical exercises in pandemic preparedness and even run a gaming exercise in 2016. The problem was that gaming exercise highlighted real deficiencies that were never followed up. So interestingly, I think here international organizations can play a really important role. I sat on a task force about 3 years before COVID, looking at what role the IMF, World Bank, and WHO might play in ensuring developing countries were in fact practically prepared for pandemics. But as is always the case, the focus was on developing countries, not on the industrialized countries. This is exactly what happened with financial crisis management. The IMF and World Bank and BIS created an EPSAP process just for developing countries, and then 2008 happened and they realized it was their own systems that were failing. We need to follow that example and universalize the international monitoring of governments. That's what international organizations can do quite well. Tell governments things that they might not necessarily have an incentive to hear usually. And checking on that preparedness, the follow-up of preparedness exercises is one thing that they can usefully do. And I've talked about the joining up of government. I'm running short of time. So the only other thing that I want to highlight for our discussions today is the very positive lessons, not for the leading edge of health research, but for the core lessons we know about the structural determinants of health. Because I fear those will be lost, and there's an incredibly good news story from many of the measures that wealthy countries took during COVID about how quickly the government can actually act to reduce poverty. In the United States, the actions taken in the first 18 months reduced child poverty by 56%. That's extraordinary. It's also sad to see many of those measures now reversed. I was working through the unprecedented 9 actions that the US government took, things they'd never done before: cash payments to individuals, expanding unemployment coverage, the child support for the lowest income children, the ensuring health insurance wasn't interrupted, the national paid leave policies, the emergency meal replacements across the school system, the prevention of household evictions of families, the resources for childcare. These measures, as every one of you in this room knows, are fundamental to health and to the resilience of public health systems. If you get these things right, you stand a chance that your poorest population at least have some health resilience if a pandemic hits. And we need to learn which of these measures we shouldn't be stopping because COVID's ended, but we should now be learning from and targeting in order to create a more core resilience for the next pandemic. I'll stop there.
Thank you. Thank you so much. Next, I'm going to turn to Jessica, who's led extraordinary work on the role that cryptic transmission has played in COVID-19. So do you want to share some opening remarks on what is not being discussed enough with regards to that?
Yes, so I work for a lab that is kind of a response team. So whenever there's an emerging outbreak somewhere, we use mathematical and computational models in order to provide estimates on what is the outbreak size. We look at forecasts, we look at scenario projections where we study the impact of different intervention strategies or vaccination distribution strategies. So a lot of our work was done kind of in real time, like right at the beginning in January and February of 2020. And so one of the first questions that we asked was, okay, there's an outbreak in China. Will it spread globally? And so a lot of our initial work was done on studying the effectiveness of those initial travel restrictions in January 2020 to kind of see, will the virus be contained or not? When it became clear that the virus was already spreading globally, we then kind of switched our mindset to look at asking the question, well, when will different locations kind of get hit, so to speak? And so we did a lot of analysis on studying the timing of the onset of local transmission. And so what that meant is, or what we found, was that January and February were kind of these like crucial months where you had a lot of virus spreading, but we really didn't have any way to detect it. So within the US, our testing strategy at that time was if you were symptomatic and if you had a travel history to China. And so it wasn't until early March where that testing strategy changed to give physicians the ability to decide who to test. And at that point, the virus was already kind of spreading locally within many communities in the US. And so because of kind of this lack of testing and porous kind of travel screening as well, we kind of gave the virus like a few months or a month, few weeks of spreading unmitigated. And that kind of led to big surges in the US in some locations that were hit early on. So.
Fantastic, thanks. We're going to come back to sort of what kind of infrastructure we need to pick it up early. But next, I want to just ask Merawi, so from the Africa CDC perspective, I think there were a lot of disappointment in getting access to the most important tools that we needed during the COVID-19 pandemic. Do you want to share a few thoughts on your experiences in that regard?
All right, thank you very much, and thank you for inviting Africa CDC to this important discussion. Yeah, I think the failure to get access to life-saving commodities, medical countermeasures, is really very, very huge. But why we fail? Why we fail is the whole world was ill prepared for health emergencies, and that leads into fierce market competition on all those commodities, including masks, gloves, and so on, that you name it, at the beginning of especially the first 3 months. Then that leads and derails us out of the moral obligation of saving lives globally into and having a really practice of a moral practice of public health action across the world to save lives and to take care of the vulnerables. I think this has is the whole core is we were all ill prepared for the pandemic. So, but we are not still really negative. We get a lot of positive things out of this pandemic. It's an amazing coordination, collaboration at a global scale that we see. Global mechanisms were put in place, and the research and innovation diffusion, production, and development and production, and to the last delivery, all these were really amazing. I don't think it has been done in history to have such kind of vaccine diagnostic production within short period of time. And the global mechanisms that we put in place and the regional mechanisms we put in place, like the COVAX, and when it comes to Africa, the African Vaccine Acquisition Task Team. All these are really new mechanisms that were put in place. Of course, they are challenged with financing, challenged with market competition, challenged and secure all those necessary manufacturing and so on. If you see, one of the strategies that was put in place in those days was to repurpose some manufacturing base for production of medical commodities like ventilators or so. But when it comes to the other side of the world, where there is no such huge manufacturing base, we struggled. And one other method that was put in place was a restriction, lockdown, or export ban, which will still serves the country that holds those commodities. But when it comes to us on the other side, we remain helpless. It is a kind of the solutions that serve the other side may not serve our side at the time. So, and that this context that we are operating was very, very frequently challenged. And despite all these amazing achievements or global coordination, collaboration, and innovation, production, and so on, we struggled because there was no such manufacturing base in the continent, especially in the region of Africa, maybe the same for other south regions. And there was still challenged with tech transfer for local manufacturing when we tried to reorganize ourselves to develop our own local manufacturing. We stuck with tech transfer and so on. And also when we produce, also the market was not there for the locally produced, like us, and you remember that story. So limited market, and these are really some of the critical challenges that we faced. But I can see the whole scenario on two bases, to be honest. They are from production, research development, until the delivery, the last, all this chain of value chain, on horizontal and all the administrative, like local, regional, national, regional, and continental, and all global level. In this dynamics, we all share some challenges that we didn't act on to mitigate that inequality or access to the vulnerable population group. And when it comes to our side, there is no manufacturing base, there is no trained workforce to develop such things. Of course, COVID has also leveraged us to jump and ramp up the genomic sequencing in the continent, which was not there before. Now, over 40 countries sequence COVID-19, and over 25 countries sequence COVID plus other pathogens, bacteria, virus, and so on, they sequence. This has really leveraged us. But that technology, the manufacturing and development piece, the workforce is not yet there. So on the global arena, the funding, all these things, that the commitment that was given to COVAX and so on was not really timely addressed. That has led us into this inequality and the fierce competition of the market, which has still left us vulnerable. So in a nutshell, we can't continue lamenting on those things, but what are those solutions that we need to come up with? I think that the first thing is we have seen more than enough, and regional empowerment in the production and development of and manufacturing of those essential medical commodities is the way out. It's good to have a mechanism like the existing mechanism, but it has to be shared southward. All these activities were skewed towards north. We need to bring them down to especially to Africa, where there is a huge population and a huge market in that space. So this has to be done as a solution. And we need to support local manufacturing and also support with some level of market shaping, to be honest. When they produce, we should also create that market space so that we can get this access. And we need to have that strong partnership that we got from during COVID. And it's a really amazing partnership that we get during this pandemic. So we need to leverage on that, make action-oriented, and also we need to co-create our own health agenda and research priorities in the continent moving forward. Maybe in a nutshell, in Africa CDC, summarizing all this, we put what we call it. We have been advocating since the establishment of Africa CDC, of course, but this is a time now to make it more loud and bold about the new public health orders that we have been speaking about. These are like 5 critical areas that we want to capture as. I like the way Mr. Blair has said, like, yes, there is a political will. We need to give them really a viable, doable action plan that we can deliver. This is the action plan that Africa CDC is proposing to the whole globe, particularly with the political leadership of the continent. We have a very huge ownership and leadership of the political leadership in the continent that we need to leverage on. So we have these 5 areas that, as a new public health that we put. One is establishing or strengthening the national public health system and national public health institutes. These are national public health institutes which house the IHR core capacities and all those things that we see, research and development, workforce development. These are critical components that we need to strengthen that in the continent. The second one is workforce development. We have seen especially when it comes to clinical trial and so on, that space is not really covered. We need to bring that to the south, and that workforce development. We have put in place as Africa CDC some initiatives and support to bridge those critical skill sets, but we need more workforce development in that space. Maybe the other one is like the local manufacturing. Local manufacturing is very very important space that we have been struggling. And if you know, if you remember that we consume almost a huge share of the global vaccine, but we produce less than 1% of our need in the continent. So bringing that local manufacturing to vaccine, diagnostic therapeutics is the way out. We can't really afford to have such kind of lockdown and left vulnerable and so on kind of here and there moving forward. So we have this big initiative called Partnership for African Vaccine Manufacturing, PAVM. You have heard about it, and we have set a target to reach around 40% of our need by the year, 60% of our need by the year 2040. So this is a big initiative that we want to scale up to diagnostics and therapeutics and so on, all other essential medical commodities. Finally, a partnership is the other component of the new public health order that we are looking into. This is like a space where we really want to leverage on with trusted, transparent, action-oriented partnership with co-creation of our own health agenda in the continent, especially in our region, is completely different from the north. We have the huge biomass. We have a huge burden of infectious disease outbreaks. If you know more about that region, over 150 disease outbreaks every year we reported. There are so many unreported. Of these health events in general, but of these, like 90% are infectious disease outbreaks that we are dealing with, viral hemorrhagic fevers and so on and so on. So that orientation is a little bit different. We have also a triple burden of diseases, like non-communicable diseases are also coming and so on. We want to co-create our own health agenda in the continent so that we can be really of safeguarding the global health security for that matter. If you secure there, contain, control the outbreak at the source, then the whole world will be safe and easy to live, to be honest. Finally, we are encouraging and moving to domestic financing. I like what Mr. Blair has reflected this morning about resource economic viability and showing the political leadership about the contribution of health sector. We were assumed to be like the mere consumer of the economy. Rather, we can contribute more into that space. You have seen in this past 3 years about how far we come and how big the health sector in science innovation and contribution to economy. So this will lead into more viable domestic investment in the continent. So these are some of these critical areas that we are flagging as a way to action for our continent and for a call for the whole globe to act together to safeguard the whole of the safety and security of the world. Thank you very much.
Thank you so much. I think there's so many thoughtful comments. I think we're now moving into the Q&A section. So you are welcome. I'm just trying to connect my app to the internet. I don't know if one of the working team could perhaps just help troubleshoot on the iPad. But while we get that sorted, so you're welcome to submit questions for the panelist through the app on your phone. I think we also have some roaming microphones ready. But maybe just as a starting point, I would like to turn to Jess. So Merawi mentioned how there has been exciting developments in new infrastructure for surveillance in Africa as a response to the COVID-19 pandemic. Based on your sort of research and insights on that, do you think it's sufficient, or what do we need to really be able to pick up early on that there is new trouble brewing?
Yeah, I think that's a really good question. It's the question of the day, possibly. So this cryptic phase, which at least how I've been referring to it, is the early stage of a pathogen outbreak where you don't really have the capacity to test and kind of determine how much spreading is actually happening. Can also be paralleled in kind of the emergence of a new variant as well. So you can have the cryptic stage, the cryptic spreading of a new COVID-19 variant. And so I think both of these can apply here. Now, for surveillance strategies, I think there are kind of a couple different ways we can beef that up as we prepare for the new emergence of new variants or even the next pandemic. One is data in general, and Sir John brought this up in his talk of creating this essentially we need this centralized data sharing platform that contains not only like genomic surveillance information, but your typical kind of epidemiological, like line list data, information on epidemiological features of the new pathogen. And we need that to be machine readable. We need it to be accessible to everyone and open to give you kind of insight into what our lives were like as modelers. The initial sort of like data that we were trying to find and generating were from collecting PDFs from different websites or scrolling Twitter, which we should not collect pandemic data from Twitter. And so having something that is like robust and resilient and is long lasting. So right now we're seeing a lot of data sharing platforms just run out of energy and run out of space. And so in this time now, we need to figure out how do we support these researchers who are generating and supporting like these data sharing platforms. The next is creating these surveillance networks that are kind of optimized to give a global perspective on the spreading of whatever pathogen you're looking at. And so some of these look like genomic surveillance systems that are strategically located globally, also like wastewater, environmental surveillance. And these can be used as sensors to kind of give us insight into what is happening and provide situational awareness. And something I'm excited about, at least within my field, is that we can use mathematical models to kind of figure out what is the optimal location, how many of these like these sensors are like feasible to place. And so that's the second point. And then the third point, which George kind of brought up in his opening remarks, is like during this like cryptic phase, how we present our model information is very important. I don't know if you all remember the early kind of discussion of mathematical models predicting these epidemic curves that essentially said everything would blow up. But what was lacking was the understanding of those assumptions going into those models. So we were still in this cryptic early phase where we didn't have a lot of information, so we had to make a lot of underlying assumptions. Some were right, some were wrong. We were scientists who were trying the best that we can, but we really need to figure out and kind of talk through what is like the appropriate way to present the information, especially when it comes to modeling results to the public, to public health officials, to cause not to cause panic, but to inform, because you have at the same time you have the pathogen spreading, you have this infodemic that's also spreading. So you have these two contagions that are interacting and affecting one another in different ways. And so during this time when information is critical and public response is important, we need to figure out what is the best way to do that.
Ngaire, to come to you, Merawi mentioned and placed a big emphasis on regional collaborations forming. So even though the government is the traditional unit of response and the pandemic affects everybody, sort of regional partnerships for manufacturing and for sort of responding, for pooling resources has come to the fore. Would you like to comment on that?
Yeah, I mean, it goes to why it's worth institutionalizing as the Africa CDC is and as we've done in international organizations, because there's sort of three things that those organizations can actually do. And one is to actually get countries to share information in a shared way. It took the world a couple of 100 years to get to the international health regulations, and it's hard, as we've seen with the WHO and all the political, but you actually need that at the core, and having an institution do that and enforce it, trust but verify, is worthwhile. Also to just to check that countries are doing what they're saying, again, the verification. But also, and this is really important, to pool support. Merawi mentioned COVAX. We shouldn't think that just because it didn't work as we wanted, that kind of cooperation always fails. It doesn't always fail. And the fact is that when countries pool, for example, their credit ratings, a group of countries in the CAF that have a B credit rating, when they pull their credit ratings, which are all B, they get a collective credit rating, which is A. And that's why you get this leverage, which enables you to actually deliver resources to where they're needed. And I think that needs to be part of the plan. The other thing I did want to say is, it's so fascinating listening to Jessica and John and the scientists talk about getting the data absolutely right, because it's sort of like watching a Maserati racing a kind of the clapped out old bus, which is government, you know, and that sort of, and one of the questions we grappled with as a school of government is, how do you get politicians to get their heads into thinking critically about what they're doing, instead of just immediately assuming that what they're doing must be right because they're keeping on telling people it's right in speeches. And the thing that we discovered was, we did something pretty simple in the School of Government. We created the Oxford COVID Government Response Tracker. And what that did is collect every week exactly what every government in the world was doing in 18 different areas of policy. Simple tool. We didn't have time to be analyzing the effectiveness of those measures, but what it did is it meant that every single meeting of Britain's COVID-19 government task force, every meeting of the Ho Chi Minh City task force, every meeting of the New Zealand government on COVID began by looking at our government response tracker. And it was just because what politicians are interested in is anyone going to get ahead of me on this, right? Is that they're going to do better, right? There's a fear that someone else might do better. So the simple information about what other governments were doing at least had them ask questions and say, well, why are the French, particularly for the British, why are the French doing that? You know, is it likely that might work? I think we've got to work with what we know is likely to provoke. You know, it's another variant of what Tony Blair was saying. We've got to work with what we know provokes a political interest, questioning, and then a sustained attention.
Mm-hmm. Yeah. Merawi, I think we've got only a couple of minutes left, but just wanted your last reflections specifically on how you envision the research infrastructure developing within and led by the Africa CDC in response to what George was mentioning now.
Thank you. Yeah, with regard to the whole health emergency, for that matter, and particular with research and development, that space is not yet really well navigated in our region. So we are bringing more talent to that space, and we are, as Africa CDC, we have some initiative to support such training programs, so that we have this one. In infrastructure basis, the whole surveillance system, our surveillance system is relatively tied with the existing health sector reporting mechanisms, which are pretty much delayed, not digitized, and hard to have, in some places where there is digitization, hard to also interoperability across different geographics are not yet there. All this needs really a strong work to have a visible early detection, as well as also a structure where we can also develop our own products in-house. This is like HR infrastructure needs. I mean, when I say infrastructure, the systems, policies, procedures that we need to observe, the regulatory mechanism, all this needs to be put in place. This is what we are really pushing forward as an agenda to the African Union. And now, recently, the African Medicines Agency is now coming into. This is a regulatory agency of the Union. This will help to cater all these regulatory processes, and also encourage more research and development, and that this space is a lot to navigate in our country. This is also, it's not like a drawback. I see an opportunity to contribute to humanity, to be honest. This is the way we see, reframe, restructure things, that the way we see and operate in the continent. It's not like we always go out and buy and bring or get donation and get vaccinated or do diagnostics. We want to really do it in-house. That was all those infrastructures that we want really built in. So we have a very favorable environment now from the political arena as well as the African Union initiative. They call it the Agenda 2063, which aspires to have an integrated, healthy, wealthy continent by the year 2063. And in that platform, there are flagship programs, one of which is free trade agreement, which enables people to produce this side, to sell the other side of the continent freely, easily, and so on. This also needs, of course, all those regulatory processes that need to be observed and so on. So there is a possibility in that space that we can really navigate and do and produce locally. And there is a huge population of 1.3 billion, which soon will come 2+ billion in the coming years with the current estimated trend. So all this really needs the infrastructure, the human resource, the systems, policy, procedures that need to be put in place, the regulatory and so on. All these are a work in progress. We are really pushing hard in that space, and we all need to contribute towards that. Thank you very much.
Thank you very much to all of our panelists for sharing your expertise. You are incredible, and also for the tremendous contributions you've made to the COVID-19 pandemic.